person. But it's also things I have learned from my patients, I think. So I will talk about the importance of focusing on affects in trauma-focused IPT. And the picture here is a modification of our mood event illustration in IPT, where I think that when you talk about mood, it's about symptoms and affects, relational needs, and current event, that we are linking them all the time. And it's about the present, not the past. And thing that I want to bring up today, it's the importance to highlight an understanding of the symptoms of PTSD for the patients. That it's not something that just comes up. It's a part of being traumatized. It's a symptom. It's not you. And I will talk quite a lot about the mood event connection, working with trauma patients, and the importance of communicating needs, and in important relationships here and now, to kind of not be re-traumatized all the time, because you're kind of living the trauma, instead of start to communicate needs and stand up for yourself and things like that here and now, instead of kind of go back to trauma time when you get flashbacks and things like that. And well, helping the patient to stay in the present moment. So that's kind of my key points here today. And I want to show this picture. It came up in my, I think it was on Facebook or Instagram or something during the pandemic, and I have showed this picture for my patients, and they really like it, because I think it's kind of shows what we work with in IPT, and how it is to suffer from PTSD. It's like you have a burden on your shoulder that nobody really sees it, because, well, you're here and now in your life, but it's something that's sort of, it's sort of a filter that you have to deal with in your daily life. And then different kind of things is going on. You get some bad news. You get stressed up for things like that. It's maybe a dispute and things like that. And you need to carry around this. And then something, quite small things happen. As in this picture, it's like you step into something, and it hurts a little bit. And both the environment and yourself, because I think it's a brain that hears who says, I think you're overreacting. That's nobody can really see that it's not really only what's going on here right now that makes that this happening that happened this week when you had a dispute with your partner or whatever it is that brings up. It's also all other kinds of stuff, and it's really hard for your family to understand how difficult this is for you, and you always also kind of invalidate yourself, that this is not really a big deal, why I'm such a drama queen, or whatever, that this is really what I think IPT is about for traumatized patients, to understand that, well, you need to deal with things that are going on here and now, because you need to get agency over your life, but you need to validate yourself and understand that you're doing a really hard work to deal with your trauma symptoms and stay present here and now in what's going on in your life. And a colleague of mine made a qualitative analysis regarding patients describing if they had any improvement or their experience from participating in trauma treatments a few years ago. And it was not IPT, it was prolonged exposure and EMDR. And the reason why I'm mentioning it here, it's because it was what did the patient felt that it was helpful for them, and why, and things that they thought was helpful, being able to participate in a trauma treatment, was ability to manage emotions, and having a relief in symptom presentation, but also that when treatment was helpful, it was an increased access to stay present in the moment, to stay focused here and now, and not suffering too much from flashbacks and things like that, or start to dissociate. And they also highlighted functioning in relationships and other social contexts. And that was something many continued to lack even after treatment. That even if EMDR and prolonged exposure helped them to deal with affects and to be more present here and now, they didn't had a chance to work with interpersonal skill deficits or problems in relationships that was part of the trauma or the trauma symptoms. And that's why we work with IPT, right? Because people need to have a life, even if they can deal with trauma symptoms, they need to function in relationships and things like that. So my personal journey from I said wrote this from catharsis and exposure to trauma-focused IPT, because I am psychodynamic in the background, and I've also been working with prolonged exposure therapy and things like that, and I think many different trauma therapies can be helpful, but some example why I like IPT is that many patients don't want to talk about the trauma. They want to get better, and then it's really good to talk about how are things been since we last met. And also there is so much going on in the patient's life that it's not possible to, or not really helpful to talk about things in the past. They need to deal with their current life, the current relationships. And many patients that I meet, they have so many trauma events and different traumas, so you don't even really know where to begin. And actually, I think it's kind of a relief for myself not to deal with nightmares, because I I realized that work a lot with traumatized patients, then you get trauma symptoms yourself. So some stories I will probably never forget that I have been witnessing, or how you deal with it, or what you call it. So I think IPT is a really nice therapy to work with, because it's good for the therapist also, not to need to be part of so many awful stories. Actually, it's more healthy to be part of a history when you can deal with disputes and losses and role transitions in the life, that you can be part to write a happy ending in the life here and now. And I also think that it was obvious after a while, after working with IPT, that patients filter the present through the trauma. So you need to help them to see what is trauma symptoms, what is affects, and what is symptom, what is feelings about what's going on here and now, and well, so on. You need to help them to sort these things out, because it's really hard for them to understand, and they're all the time afraid that they start to become crazy in a way that they aren't. And it's also obvious that if you traumatize, it may be so that you have severe interpersonal difficulties because of the high arousal that is part of trauma symptoms. And Paul Voxel, he hasn't been working with IPT, and I don't think with traumatized patients either, but he said something once about, well, he compared psychodynamic, more traditional psychodynamic therapy with relational therapy. And then he say, why take a detour through the past to work with the difficulties in affect and relating when these issues arise and unfold here and now in current relationships? And I think that was what we are working with in IPT. So and definitely with trauma patients. So that's kind of and I've been working both with group therapy for PTSD and with individuals, and it's many interpersonal traumas. Most of them is where the trauma has happened in the family. So it's kind of it's your own tribe that is unsafe. But I also meet patients who has moved to Sweden because that there is a war going on in their country, and some of them have experienced several wars, and most of them I meet, they have come to Sweden and settled down really well, and has been very eager to learn Swedish and start to work, and really work really hard to come into a role, be part of a role transition from one life in another country where a war has been going on, and come to Sweden and start a new life. And then something happens that maybe they hurt their shoulder or something. And the world really crashed down. It's like everything comes back to them. And often they come to us and have chronic pain or something and can't sleep, so they don't really think that it's PTSD, even if they have been meeting a doctor for a very long time. So you really need to learn, help them to understand what trauma is. Well, and well, I also meet patients, of course, that has been suffering from rape and things like that from people they don't really know, but most of them have that kind of background that I said. And I also work with patients who has been part of criminal gangs and have been traumatized because they have been treating other people really bad. And I want to say that if any one of you have thoughts of starting group therapy, don't mix these patients together, because we did that once, and they, they can really, well, even if they are nice to each other, they can feel, if some of them have been using a lot of violence, and another has been abused, it's something that's going on that's not really good for them. So be aware of the mix in the group, and it's also, if you have many patients who have been abused in their family, and maybe have one patient that has been suffering from war, the trauma is the way the trauma affects the here and now, it's completely different if you have been abused towards your parents, then you don't trust anyone. But if you have been a part of a war, then the enemy is someone you don't know. So interpersonal dilemmas in that is going on here and now, they can be completely different, and that could be a good thing to talk about. But sometimes then you need to have a good mix in a group if you're working with group therapy. So that's part of my therapeutic history in with these patients. And I want to say a few things. I want to talk a little bit about the sick role, because when you talk about trauma, it's really easy to think that trauma is an event, and of course it is. It's something really bad has happened. But when you work here with traumatized patients, you need to remember that trauma is a condition. It's symptoms. So it's important to always come back and say that this is not you. This does not define who you are. This is a condition. And it's like working with patients to understand that PTSD is making it ego dystonic, instead of that the symptom is something that they think is just happening and that's how they are. So just to remember the essential things about the sick role in IPT, that it's not your fault. It's because of your trauma symptoms. If, oh, I became really dramatic, we start to argue about a really small thing and I just went crazy. Yeah, it's not really it's not strange at all. You felt really misunderstood, and this is really similar to when you and your ex-boyfriend was talking like that. And do you remember we have been talking about that, that you need to remind yourself that you're not with him anymore. This is because of your trauma symptoms. Let's see what's happening and if we can do something to prepare yourself for your next discussion or things like that. And uh, but also that you can do something to understand your symptoms and uh, work on being as present as possible in what's going on here and now. You can feel so much better, and that you need other people. That uh, if you start to talk about how you feel and share it with other people, you are not alone. So you all know all these things that I'm talking about, but I think it's important to highlight it. Um, and actually, this is something I come back to all the time because they forgot. Oh yeah, that was kind of a flashback, or yeah. Um, sorry. Yeah. Regarding this, that you can do something yourself, uh, that you have to take care of yourself. I don't know what you say in English. In Swedish, we say like self-care. It's what you can do, and not only going treatment, that you need to sleep good, don't drink too much alcohol or smoke weed, eat well, but also to understand. So I talk quite a lot about different emotions. Why do we need affects? If they haven't seen the movie Inside Out, I tell them to do that. uh, we talk about attachment needs, relational needs, and regarding the sick role, we and try to not blame themselves. It's always kind of a way try to work with externalization. This is not you. This is the symptoms, and some patient you need to work with how to manage when they start to dissociate, how to help them to stay present if the emotions or the anxiety gets so high when you talk about things that um, mm, stress up a lot of emotions. And then I work with different kind of way. It depends on which patient it is, how we do to work with staying in the present. But well, we can come back to that if you want to. Anyway, yeah. So helping others and yourself to understand what you need. That we talk about the difference between fight and flight and freeze, so you can stay in the present instead of go back in trauma time, so to say. And regarding a timeline in IPT, we normally do that. I In one way, I do that in when I work with PTSD patients as well, but not. It's not trauma. It's not like a narrative exposure therapy. It's more like what has been going on in your life. So you need to know what kind of trauma the person has been experienced. And the reason why it's that we want to know how does the trauma most prominently express itself now? In what way is it a problem for you? Is it to trust other people and let other people into your life, or is it that you don't want to be alone, or what kind of interpersonal problem is a consequence of the trauma you have been experiencing? So in that way, it is good to know what has been happening, but it's not trauma exposure in if you compare it to other treatments. And just to well, highlight, here is a timeline with a very complex patient. It's in Swedish, so you won't understand what if you can't Swedish. You know a little bit, John. I know that. But anyway,
Not that much.
this is a girl, she's 27 years old, and here's all her trauma events. But as you can see here in the circle, that here's where we are working. So even if you know uh, she's been through a lot, but we're interested in what has been happening lately, what's going on there. Um, um, that's something we can deal with. And well, just to mention, here and now. And I want to say something more because, you know, some of you know that I'm just in the ending to finish my thesis, and it's about interpersonal psychotherapy for eating disorders. So I want to mention some things regarding IPT and anxiety disorders in general, because I think it's important to mention. As you know, if we don't talk about PTSD, more anxiety disorders in general, IPT has not shown the same level of effectiveness as for anxiety disorder as in depression. So we need to know more how to work with anxiety disorders in IPT. But interestingly, there are many studies that IPT with depression, with different kind of conditions and populations with comorbid depression have shown promising outcomes. That's interesting, I think. And in the trauma study, John and colleagues presented 10 years ago with trauma patients, if I have understood it right. Trauma patients with comorbid depression had better outcome with IPT than those receiving CBT. And in one of my studies with IPT and bulimia nervosa and some comorbid depressive symptoms, we saw that because they had weekly, they measured every week both eating disorder symptoms and depressive symptoms, we could see that if the patient became better in their depression 1 week, it helped them to become better in eating disorder the week after, even if the focus was on eating disorders. So it's something about that IPT is really good to help patients with depressive symptoms, and in some way that seems to be helpful for the anxiety disorder as well. That's my thought, and I think that's something we need to know more about. And it's another PTSD study by Felton, where they also saw that reduction in hopelessness and depressive symptoms was a mediator rather than perceived social support. So it's something to really relinquish hopelessness and emptiness and things like that. That's important for these patients. And also a study in social anxiety and depression that we have seen at IPT may work more through common factors than with even if it's important to work with our focal areas and things like that. It's the common factors is really important as mechanism of change in IPT. So working with affects, for instance, is something that is probably really important. Also the therapeutic alliance, and in some way we two Swedish studies have shown that even if IPT don't work to help patients to be better to mentalize, for some reason they start to mentalize during the treatment. And I know that you have been done some studies about that as well, John. So with all that said, I think that it's something about how to work with the symptoms and then come work really through that and come into the affects that we do in IPT by working with mood event. So I think that this I'm sorry, I start to think in Swedish now. I have to I have a picture here I want to show you anyway. It's that you all know this mood event illustration that we have that in all our books about IPT. And John, I think both in both of your two books about PTSD and IPT, you have written very well about the importance to always link mood and event, and from a wider perspective that you put mental disorder into interpersonal context, but then go deeper and deeper into affects. And when you work with traumatized patients, it's the mood is both PTSD, its comorbidity and its affects. And regarding events, then depending on what's going on in the person's life, it's about role transitions, it's about disputes, interpersonal difficulties or losses. And you need to really, how have things been since we last met, to help the person to understand that in which way the PTSD symptoms is in some way a trouble for them. And when you think about, it's not only about it's to say that, well, that's a part of your PTSD. It's really to see that this is intrusive symptoms, or this is avoidance, or this is hyperarousal, or this is mistrust, or things like that. So I work with rating scales with patients all the time to really help them to see in which way they have PTSD symptoms. And it's really nice when they can see that they don't have so many, but actually they feel more. They have more feelings, or they can cope with feelings in a new way. And regarding comorbidity, it could be depression, it could be chronic pain, it could be Well, lots of different things. That's part of having PTSD, is that you get very many different symptoms. In Sweden, it's like that anyway. I guess that's could be like that in other parts of the world too. And then, of course, it's the affects or the feelings or the emotions or whatever you want to call them. And when you talk about affects, then it's both regarding things that happenings uh, during the week. Maybe you need to tell your boss or your partner or your mother something that you're a little bit scared to tell them, and that stress up a lot of emotions. And
Mhm.
that's things you need to deal with. But it could also be that you uh, um, having PTSD symptom stress also up different feelings. It's many patients have problem to talk about their symptoms because they have so many feelings towards that, and they sometimes I think that the feelings is something they need to help to understand that well, the shame you felt and now, when you felt misunderstood, is the same kind of feeling that when you, uh, when your father did that and that and that, but that's not happening right now. So it's kind of a way to understand that it's the fee to sort things out here. And I also think that's it's part of the um, challenging way to work with patients with anxiety disorders and depression. Oh, sorry, even if even if it's eating disorders or PTSD or things like that, it's that sometimes feelings is something you really need to listen to because they are trying to tell you something important about what you need here and now in this relationship. And sometimes they try to tell you that don't go there. That's really dangerous for you. It's much better if you do like this. And that's the symptoms. That's that. And you need to help the patient to understand that you have to stay into this situation and communicate your needs here. Otherwise, you won't feel stronger and feel the agency and things like that. And you need to stay here and deal with your problem instead of start to get flashbacks and uh, think about how miserable you were when you were 8 years old. So you need to help them to stay in the present. And this picture is a way I try to work with communication analysis with my patients. That you try to, I guess you all do this. But that you what did you say, what did he say, what did you feel, do you know what he felt, do you know what he thought, you think he thought like that, but did he say that, okay, so that's kind of your fan imagination, but I also try to not only talk about words and thoughts and feelings, I also talk about which symptoms did you get here? And also, do you know what intention she and he had, or what were you intention? Because to help to see uh, what do I need to deal with here, and what is part of the trauma problem that I also need to understand. So it's all both problem solving and to understand the the way you suffer from the trauma. Um, right. I can see that I've been talking a lot, and maybe I because I have said so much more than that I have planned. But maybe I could show this picture as well, because I think it's something I use a lot with my patients. It's this the window of tolerance, that when talk about feelings, that some feelings and PTSD symptoms is when you have really, really strong feelings, and sometimes it's when you don't feel anything at all. And when I do a communication analysis, for example, I ask them, on which level do you think your feelings was? Next time, is it possible to, can you see when you not is a 7, when you maybe is a 3? What could you say then? Because it's not helpful to communicate your needs when you're hyperarousal or hypoarousal, because then it's really hard to uh, interpret other people's intention, or communicate your own feelings, because they are so strong, too strong. Right. I will not say everything I had planned, but I can end up with this picture that it's kind of my take home when I work with IPT. It's that listen a lot, and you need to ask a lot of questions, not become the expert, but help the patient to become an expert by asking curious question about mood and event, and connecting them together, and always pay attention to the emotional content, what's happening here and now, especially in relationship, emotions that are trauma triggers, emotions that arise as a result of symptoms themselves, and of course the emotions in the therapy room. So well, thank you for listening.